be that the tube or the book. I'm coming at you, and I've got some questions to be answered, quite frankly, mainly plastic surgery. So if you're interested in that sort of thing, then that's what I'm going to be doing. And if you've got a question live, please answer one. Ask. I'm answering. Let's get this right. I have got a question from Sassy, which I mustn't forget because I just seen it a minute ago on TikTok, saying she had breast implants 2013, and now whenever you sunbathe, you get burning pain around the scar, around the areola. So I'm assuming you had a lift, did you? Or maybe you had the implants input through a circumareolar incision. Anyway, that's not the point. So you're getting burning in the scar and like hot feeling in the implant. Is this normal? No, Sassy, it's not normal. 2013, that is, long time ago, 10 years ago. So I would be concerned that this is something other than your implants. Now, when you first have implants put in, you can get funny feelings. You can, particularly silicone implants. In fact, silicone implants often feel cold. Polyurethane implants often feel warm, but you can feel funny temperature feelings with the implants when you first have them put in. And but if you've had like no problems since 2003 or 13, when was it? Anyway, whenever it was, 13, it wasn't it? Then I'd say this is abnormal. To be honest with you, I don't think it's anything worrying. I wouldn't be worried about it. It may just be that you're getting sunburnt, and it may just be getting burnt on the skin, and you're just feeling like the implants are hot, and you're feeling like the scar's kind of uncomfortable. It's not something that I've heard before, but it's also not something that I'd be particularly worried about. As ever, Sassy, talk to your surgeon. If I'm your surgeon, which I don't think I am, but sometimes people have funny names on these things. So if I am your surgeon, by all means, come and see me. I'll be happy to see you and check things over and check everything's okay. But as I say, it doesn't sound like anything to worry about, and it might just be the fact that we've got hot weather and you're feeling hot. People get that without implants, and I think when you have implants, sometimes you associate things with the implants which may not necessarily be related to the implants. So it's not something I think is directly related to the implants, especially after so long after having them put in. As I say, you often get weird feelings, but that's usually in the first few months and maybe a few years, but certainly not 10 plus years later. So thanks for asking, though, by the way. Do we use, next question, unless Sassy, if you're there and you want to come back at me, by all means come back at me. I'm always happy to be confronted, as it were. Do we, who's Staiano 007 and doing all these likes? Who's this? Staiano. Do we use Motiva implants? Yes, we do. I'm not really linked to any company. I know some people only use certain company implants, but I'm not linked to any company. So as long as the hospitals can get them, or as long as we can get them, and they're sort of acceptable, I use all makes. I use Motiva. I use Polytech. I use Nagor. I can use Mentor. I don't tend to use much Mentor, but I can if you want Mentor implants, that's fine. I kind of offer patients all the textures. So Motiva are only the micro-textured variety. If you want, I offer polyurethane. So Polytech, Polytech are the only company that make the polyurethane. So if you want polyurethane, you kind of have to have Polytech. But if you want micro-textured or macro-textured or smooth, there's several companies that makes them. And if you have a strong view about a certain company for whatever reason, and as long as it's a sort of reputable company that we can get, the hospitals can get, then that is absolutely fine. And Motiva is one of those companies, and they're fine. And as long as you want micro-textured, of course, if you want smooth or macro or polyurethane, then Motiva don't make them. Yeah, so we do use Motiva. Do any of our surgeons have experience with Pectus excavatum? I mean, I guess, yes, I mean, I do a bit, not massive. So Pectus excavatum is a concavity in the sternum, in the middle of the rib cage, as opposed to Pectus carinatum, which is a convexity in the sternum. So it's a chest wall deformity, and sometimes we will see it in patients who require breast augmentation, because it can cause breast asymmetries, or they might just be wanting breast augmentation to kind of make it perhaps a bit less obvious. So I have seen and treated patients with Pectus excavatum. I haven't, or at least not since I was a trainee, I haven't specifically treated the Pectus excavatum. So if you want the ribcage deformity treated, then that's something I haven't particularly done. At least not as a consultant. I've done it in training in terms of making custom-made 3D prosthesis implant to fill up the defect, or the cardiothoracic surgeons will put in bars across and fix the chest wall deformity. So if you have a chest wall deformity, it's always important to look to see whether you will need to get that chest wall deformity fixed first. So I wouldn't be fixing the chest wall deformity. That would be either a cardiothoracic surgeon or a plastic surgeon who is doing that sort of stuff. But often we don't actually fix the chest wall deformity if it's not severe, and you can put implants in, but it's important to be aware of if there is an angle to the chest wall. Implants can accentuate that. So if your nipples are kind of pointing a bit like medial or lateral, if you put implants in, they can look like they're pointing more medial or lateral, a bit like a ship. A ship goes a little bit off course. It's not too bad, but as it continues to go off course, the difference from the normal course accentuates. Yeah, so going like that, a little bit off course, not too bad, but as it goes more off course, it's more of a difference. So the nipples can look more. Anyway, so it's something that's important to sort of look for and be aware of prior to putting implants in, because you don't want to make the asymmetry look worse. But I wouldn't say I've had massive experience, to be honest with you, but I have treated literally probably a couple of patients with it, and it does help, as long as you're aware of problems with angles if the chest wall is severely angled in. So happy to talk about it. As I say, if you want specific treatment for your Pectus excavatum, and actually I would always suggest you look into getting treatment for your Pectus excavatum first, because if they are going to fix your Pectus, you don't want to have implants now and then they fix the Pectus and then everything goes awry. So you need to fix the Pectus excavatum first and then consider having implants. So if you are so we would suggest you see someone about that. And if they've decided they're not going to fix it, then yeah, fine. We can talk about doing things with the breast. I suffer from hypertrophic scars and I want a tattoo removing. Would the scar also turn hypertrophic/keloid? Quite possibly. So yeah, if you've already got a hypertrophic scar, or if you're actually saying I suffer from hypertrophic scars, so if you've got more than one hypertrophic scar, then that is a concern. And all things being equal, I would suggest you shouldn't have a scar if you didn't kind of need it. So it would be a big negative against having something done, I think, if you've already had a hypertrophic scar previously. If there's a reason for your previous hypertrophic scar, so if you had a wound which took a long time to heal, and that might have been the reason for it becoming hypertrophic, then there might be a case to say that, we could give you another scar and hope that if this one doesn't take a long time to heal, it won't go hypertrophic. So if you've got a reason for the hypertrophic scar, that's actually a good sign. But if you've got no reason for the hypertrophic scar, if it just healed normally, and particularly if you've got more than one hypertrophic scars, then that suggests that maybe you form hypertrophic scars. So if your body forms hypertrophic, or worse still, keloid scars, then yeah, if we give you a scar, then there's a good chance it's going to go hypertrophic or keloid. So you would probably be best off not having something done, especially like a tattoo removal or something like that, because it could look a lot worse than the original tattoo. So yeah, I'd steer clear. How long should I leave in between after having laser tattoo removal before booking in for surgical tattoo removal? Well, I guess there's two aspects to this. The first aspect is that you want to see if the laser tattoo removal's worked, because you don't want to go in too soon if the laser tattoo removal is going to remove the tattoo. Oops. But and the second, I guess, is like the healing from the laser before doing the surgical one. So it depends on how badly damaged the laser tattoo's going to damage the skin. But assuming it's not too badly damaged in terms of blistering and things like that, 3 weeks. If you do get a burn or a blister or something like that, probably 6 weeks, because you want everything to heal properly. And we will assess you and see if the skin looks a bit red and a bit inflamed, we will probably delay it. So you want the skin to have settled down completely. So if you've had laser tattoo removal before and you kind of know how long it normally takes you for that skin to settle, then you know. So it'll be that. But if you haven't, then yeah, 3 to 6 weeks. See how it goes, see how it settles, I would say. How long does it take for a cyst to heal on the nose? I'm assuming you mean after you've had it removed. Is that obvious? I'm going to answer the question like that. So as if you're saying after you had it removed. So if you had it removed, a cyst on the nose isn't great. Nose, everything's quite tight on the nose. So we would aim, you aim for the skin to be healed in about 4 days. So you normally have stitches in. Stitches come out 5 to 7 days post-op. We normally do 7 days, but anywhere between 5 to 7 days is fine. So the skin's usually pretty well healed by 5 to 7 days. So that means the skin's healed. So you don't need a dressing or anything like that. You'll have like a red scar. So in terms of that, so it'll be healed, but it won't really be full strength. So in terms of the scar getting stronger, it will be a couple of months for that scar to sort of get strength to it. So personally, I don't tell people to do anything like massage or anything like that until 6 weeks post-op, because we want to get a bit of strength into it. And even at 6 weeks post-op, it'll be quite red probably and a bit obvious. So it'll be absolutely healed and you can kind of do stuff and live your life, but it will be quite red. And I normally say it starts at 3 months. And it can take 6, 12, 18 months for it to really properly settle. So it can take several, maybe many months for that red scar to settle. So, there's elements of healing. So say it'll be healed in a week, but it might take many months for it to properly settle, and for it might be a bit of a dent or a bit of a bump and this and that. So we're getting massaging for the months. So it does take months for it to sort of really properly sort of settle down. What causes keloid scars? I don't know. I don't know if anyone knows. There are no animal models. No animals get keloid scars. And the sort of science of scarring is quite a big area in itself. Fetal wound healing, fetuses heal without scars. So we don't really know why some people get keloid scars. Therefore, we don't really know how to treat them, to be honest with you. And what we've got to treat them. Oh, Josephine saying hi. Hi, Josephine. I'm very well, thank you. How are you? Nice to see you here. What we do know is that some things work, but we don't really know how they work. It's kind of like we found out that they work, and then we've tried to explain it like retrospectively. So things like steroid injections, things like covering them with tape, silicone tapes can help. So certain things can help with keloid scars, but because we don't really know what causes them, we can never really guarantee those things are going to help. So it's always difficult in the private sector. In the NHS, well, I don't even know if the NHS treats keloid scars, but when I was working in the NHS, it's a lot easier to treat people because there's kind of less on the line. But in the private sector, obviously people are paying, and so it's a little bit more difficult if they're paying and you're saying, well, it might work, it might not, because it's like, what do you mean? You're going to take my money and it might not work? You're like, well, yeah. Probably don't put it quite like that, but that's kind of how it is. You cannot guarantee it's going to work. I mean, to be fair, it often does work, and certainly the steroid injections can help, particularly if there's itch involved with it. It really helps with the itch, can help with the lumpiness, the redness. Silicone strips, not so much, but also they're less invasive silicone strips. You can just buy them from the chemist and just put them on. Massage, moisturize is good. So these things are good, but we don't really have any really good treatments. I mean, sort of late stage keloids, you can do radiotherapy, can be very effective, but that's quite an extreme treatment, because as you get into more extreme treatments, you get into bigger side effects. So you've always got to balance the side effects with the benefits of treatment. But the mainstay of treatment is, first of all, massage. Pressure is good, especially with the earlobes. You can get pressure clips, silicone gel, which if it's on your face or something, or sheets if it's on your body. Sometimes in the breast, like in the bra strap, silicone sheets and the wire of the bra can give a bit of pressure, so that can be good. And then steroid injections, well, that can be painful, and as I say, you have to pay for it, and there's no guarantee of success, but it does help often with the itch and can help with lumpiness. Other sorts of treatment, cutting them out is another treatment, but then they can come back worse. So that's another one where we say, oh yeah, we can cut it out, but it might come back worse. So it's kind of it's a difficult one. So they're difficult to treat, keloids, and it's difficult to kind of guarantee results, because it's hard enough to be honest with you. It's hard enough to guarantee results with anything, I'll be honest with you, but it's even harder to guarantee results with keloid scars, because it's not clearly known what the mechanism is. So we can't clearly say this is what causes it, therefore if I do this, that will reverse it or whatever. So it's a tricky one. So yeah. Okay, that's my last question, full disclosure. So I am going to go and get the fish cakes out of the oven, and should be back next Tuesday, barring any royal engagements or anything else that happens to come up. Who knows? But in the absence of any better offers, I will be here next Tuesday, 7 o'clock. So that means I will almost certainly be here next Tuesday at 7 o'clock. And if you have a question, email me, message me, fax me, call me, and I will do my level best to answer it. So yeah, with that being said, I'm going to stop the stream and bid you good night and have a good